So the main things that we use for the identification of AML are morphology assessment of the bone marrow, as assessed by our expert hematopathology colleagues. This kind of gives us a 30,000 foot overview, a morphological assessment of whether or not there's blasts in the bone marrow and the peripheral blood, dysplasia on the bone marrow that may suggest underlying myelodysplastic syndrome as opposed to AML or acute myeloid leukemia. But really, we now have many more sophisticated tools that we're using to aid us in the diagnosis. Some of these tools are conventional karyotype cytogenetic analysis, looking at the chromosomal structure of patients. We also have FISH probes that we use for this as well to look for translocations or different large genomic aberrations. And then we also use two more newer technologies, next generation sequencing, which looks for specific mutations within a specific gene that are known to be associated with myeloid malignancy, so MDS, AML. And then we also use flow cytometry, which is an evolving area that has really gained a lot of traction and is very important for the diagnosis as well as the monitoring of AML and remission to assess for abnormal immunophenotypes, which can help us determine cell surface markers on leukemic blasts as opposed to normal bone marrow blasts or healthy blasts or regenerative blasts, as well as it can identify what we call these pre-leukemic clones, which maybe have a different immunophenotype compared to normal, but are separate from the immunophenotype associated with that individual's AML. And so we use a combination of these tools at diagnosis. They help us secure exactly what type of leukemia this patient has. There's also acute lymphoblastic leukemia as well as acute myeloid leukemia. And then even further, we know that there are certain mutations that are prognostic, meaning that we see different outcomes depending on which risk group. We risk stratify these patients, and we see different outcomes based on which risk group the patient's leukemia ends up falling into. But I think even more importantly now and moving forward is mutations that are predictive. So we're now seeing mutations that are predictive of a response to therapy, and that's helping us guide our therapeutic choices for these patients.